We're going to hear the main findings of this systematic review, and then from Siobhan O'Neill, who's chaired the advisory group, and also Nancy Hay from the What Works Wellbeing Centre. We'd encourage you obviously to look at the reports, but also through this session to use the chat function for comments, for questions, for links to other things you think people should be aware of. And there is a link for you. The project, for those of you who don't know, is part of IPPO, which is the International Public Policy Observatory, a collaboration of a number of universities, including UCL, Queen's, Glasgow, Cardiff, and the International Network of Government Scientific Advisors and the EPPI Centre, looking at synthesizing evidence around policy in a whole range of different fields, from education to care to homelessness. And we started early in 21 and have been very much about trying to improve the quality of social responses to the pandemic. I think it was clear to us, as to many people early on, that mental health was the really big issue of the pandemic, even if the pandemic was about physical health and infection. And early on, we did events and work on what was happening to teenagers, particularly as they were locked out of school, to the elderly in care homes who were, denied visitors and often struggling. And that's what led us to want to do a more systematic review of what the evidence was saying, as we found governments all over the world, and not just national governments, but also city governments, were asking what should they be doing, what could they be doing at a whole population level, not just dealing with the most acute needs of maybe 1 or 2% of the population, but the 20–30% who appeared to be struggling with anxiety, depression, and so on. We're going to hear in a minute from Kelly, who's led the review. We've also, in parallel with review, published a sort of overview of the policy context. As I said, there's growing interest, but many governments don't quite know what they should be doing. And as recently as September this year, the World Health Organization published a survey suggesting responses globally are insufficient and inadequate. We know from many countries how population mental health issues intersect with many others. In the US, for example, strong evidence of upward trends in numbers of those suffering acute mental distress, especially actually less educated white communities. That has become a political fact as well as an economic fact and a health fact. Here in the UK, we've now had more than a decade of systematically measuring well-being since the ONS started doing so. We've had large-scale programs providing access to CBT, which started in the 2000s, have continued to scale up, and a lot of investment in research and evaluation to make sense of this. And at a policy level, some countries have had ministers for happiness, and we in the UK, you may even remember, had briefly a minister for loneliness. In our policy survey, we look at some of the things which are happening. We show that if you look at the public opinion globally, the publics all over the world now see mental health as almost equally important as physical health in terms of policy. There have been attempts of more comprehensive responses, like the Royal Commission in the state of Victoria in Australia, and lots of interesting innovations, for example, in Trieste in Italy, various programs at a local and city level in the UK, and a huge explosion of experiment with digital tools, tens of thousands of apps on the Apple and Google Play stores purporting to be good ways of handling mental health. And we also are today publishing a survey of the many policy moves which have happened in each part of the UK, Northern Ireland, Wales, Scotland, and England as well. And our hope is that what we're doing today and all of this work and all the work you're all doing is really making this part of the mainstream, one of the sort of things you would expect to hear ministers talk about. We're very used to them talking about A&E and hospitals and ambulances and so on. But perhaps we're moving to a time where it's as natural to talk about mental health, the facts, the responses, what works, what needs to be done, where there are inadequacies, and so on. So I hope, Kelly from the EPPI Centre at UCL, you are ready now to share some of the main findings from your research. The link to that is in the chat, and we'll then move on to responses from Siobhan and Nancy.
Thank you, Geoff. So just to say that I'm going to talk through the population mental health and COVID-19 review that we did. I will do the first part, and then I'll hand over to Carol, who will talk about the scale up. So when we looked at the question on kind of the most effective scalable mental health interventions to address kind of widespread mental health issues, we kind of broke this down into 3 questions. So we were really interested to find out kind of what the nature and extent of mental health issues that were arising in the general population, before then thinking about the kind of population mental health interventions that might be effective. And then also after that, think about the actual factors that could potentially influence scale up. And when we started the review, we realized that there was probably going to be quite a lot of systematic reviews in this area, and that is what we found. So for the first 2 questions, we looked at the review level evidence. And then for the 3rd question, we actually looked at primary studies. So we found 19 meta-analyses that pooled estimates of effects for anxiety, depression, and post-traumatic stress. And 2 of those reviews actually were able to compare pre-pandemic to post-pandemic data and kind of found a moderate increase in anxiety and depression. This was also supported by the cross-sectional studies, and we also found some data on PTSD. So these are the 3 main outcomes that we looked at when we were looking at the effectiveness literature. So we looked at both children and young people and adults. And what we found is that there are quite a number of interventions that are delivered to children and young people in schools. And the evidence suggested that kind of universal prevention of anxiety can be achieved in primary schools and secondary schools, and universal prevention of depression in secondary schools, but not so much in primary schools. And then we also looked at targeted prevention, and that also suggested that anxiety can be reduced in primary schools, but much less so in secondary schools. But for kind of indicated school-based programs, they can be effective for anxiety and depression. So overall, what we're finding is that depression is a little bit harder to prevent in school-based settings. When it comes to treatment, we found that there are a range of different types of interventions delivered digitally and in the community that can treat anxiety and depression. Many of these are CBT based, both internet CBT as well as kind of CBT on smartphones and mobile apps. We also found that psychotherapy delivered in community-based settings is also supportive for treating depression in children and young people. For PTSD, it's much more likely that there needs to be a trauma-based approach, and this was mainly delivered in community-based settings. So that was for children and young people. So when we looked at interventions for adults, we found that that in the workplace, interventions can be effective in preventing anxiety and depression, and community-based interventions as well, much less likely, similar to children and young people, to be sort of addressing prevention of PTSD in these settings. Although there was some evidence of it for digital interventions. but it was hard to sort of find the effectiveness for those. So even though they were attempting to deliver them through CBT and ACT-based smartphone apps, yeah, the evidence wasn't as strong. And for adults, in terms of treating anxiety and depression, we found a range of digital and community-based approaches that were effective. Again, mindfulness, CBT, internet CBT, as well as psychodynamic therapy. We also found evidence for IAPT for treating depression and anxiety, but yeah, similar as before, the mobile apps for PTSD, not as effective. So I will hand over to Carol to talk about the evidence from the primary studies on kind of factors influencing scale up.
Hello, everybody. Yeah, so we had this third question of, well, what factors potentially influence the scale up of mental health interventions and how? So this is where we looked at primary studies this time. We were interested in a definition I have here as deliberate efforts to increase the impact of successfully tested mental health innovations so as to benefit more people and to foster policy and programme development on a lasting basis. I believe that's the World Health Organization's definition. So we looked for those primary studies that aim to do that. They evaluated their scale up, they evaluated their implementation of a tried and tested intervention or programme or service. So we looked at hard outcomes of costs or increased service use, but we also looked at perhaps the author reflections on what are those factors that they said were important for successful scale up. There are other models on scale up, but we did not limit our inclusion to high income countries or low income countries. As scale parameters, where as we can see there were some that aimed to have a global reach. Some were within the system, so perhaps integrating the mental health service into an existing system where it wasn't before. And most of them were still place-based, so either within a country or a nation or within whole communities or workplaces or schools, so within a particular place. And we, as I said, we looked at those author reflections on what were those factors that influenced successful outcomes. So these are associations, but we haven't gone so far as to test the strength of association or importance. This is a list of those families of related families of factors that were mentioned, sort of grouping them together in related factors. I'm presenting them in order of most commonly mentioned. That doesn't mean that they're the most important or the order in which these factors play a role. Indeed, many of you, I'm sure you can just see there that many of them will be interdependent, interconnected, and apply at different phases of the scale up or throughout, and so on. So just we'll have a quick introduction to them. Can we have the next slide, please? Thank you. So the most commonly mentioned was about the intervention characteristics itself. So how is a change in the intervention going to increase to more people, to be in more places or delivered by more people? And one commonly mentioned factor of an intervention characteristic would be to digitize the intervention. This doesn't necessarily mean that they're completely unmanned. Most of the implementation, most of these factors were blended in some way with therapist intervention. Very few were completely automated. So it could be, say, working through, the client will work through a series of stages, might discuss the outcomes with the therapist. So they were blended, shall we say. Another very commonly mentioned one was expanding the workforce, so enabling delivery by more people and reaching more people that way by task shifting or task sharing from specialists to non-specialists. Again, this is quite specific about, this is most commonly for common mental health disorders or issues, perhaps at low severity. They're often manualized. We'll talk about that later. But this is another commonly mentioned factor to enable scale up. Related to the first, using technology and online provision to train these non-specialists. This way, you can speed up the delivery of people who can speed up the delivery, and to more people who can deliver these mental health services or programs. And another was to break down a barrier to access by enabling self-referral. So making these mental health interventions more open access, not relying necessarily on a gatekeeper to give a diagnosis and a referral on. Another, perhaps surprising no one, resource-related factors were very, very important. This was very clearly stated not only as a facilitator, but it was also cited that the lack of resources or the ending of resources or the cutoff was a barrier. Training was a major cost in new service provision. So another one, matching resources, matching the service level to client need by identifying care pathways, taking a stepped approach to intervention, identifying care pathways and pulling in the appropriate services or the appropriate level of service for client need. Integrating mental health services into primary care, that was mentioned a lot, and to go with that was a lot of challenges associated with trying to do that. If we're talking about barriers to a common cited barrier was just the institutional differences, organizational differences to try and make this happen. So this was mentioned quite a bit. Working together, leadership was mentioned quite a bit, but this is leaders who are leading from the middle. These are leaders who are effectively engaging as kind of trusted brokers, so can represent and recognize different interests and different needs of different stakeholders. I guess we're talking about. Local champions related to this were also cited to be important to promote new services, but related also to adapting to local context. Local champions were super useful here. Working together, gaining the buy-in of multiple stakeholders, including the implementers of the programme. There was talk of co-producing that service, identifying the issues and barriers. Your local stakeholders could identify the issue and barriers ahead of rollout, and their buy-in, their knowledge, and their confidence in delivering the service would be critical in ensuring what we talk about later, program fidelity. As we talk about, it was often talked about that making sure the program is delivered as intended over a period of time in different contexts and to the people intended, and obviously to the efficacy intended. Local champions and effective leaders were important to perhaps define what success would look like. In order to know what is the fidelity that we're trying to work towards. Okay, so next slide, please, Kelly.
Yeah, coming up.
All right. We mentioned a little something about defining what success looked like. Essential part of monitoring and evaluation. And again, this is something that crops up at the beginning, middle, and end. It's a factor that affects every phase of scale up. Firstly, in advance defining success, using benchmarks and indicators to measure progress against, using research and evidence for making the business case to secure and support funding, ensuring fidelity through quality monitoring, perhaps applying agile design principles at early phases for modifying and strengthening services for continuous quality improvements, monitoring the efficiency of the service. Probably don't need to persuade people of the importance of monitoring and evaluation throughout. Testing the acceptability, perhaps this is kind of an early phase factor. Again, is sort of testing the need, the acceptability, but perhaps in different locations with different stakeholders, identifying the potential reach, all of which then will feed into the monitoring and evaluation along the way. Contextual factors, perhaps these background factors are less easy to influence than the other ones that we've been talking about, but having an awareness of them, being able to adapt to them were listed as important factors that could influence that final that successful implementation. That is understanding and accommodating the characteristics of the adopting community. So one should take into account the broader socio-political context, you know, what the adapting to changing priorities have, and less able to influence perhaps, but really important to have a supportive policy and regulatory environment to enable scale up. So they're all, as I said, these are the finally, perhaps really more importantly, I mentioned before that these may be factors that in order of most commonly mentioned, but not necessarily of importance. One study made a very important point, I thought, about that combining supply side and demand side approaches. That is, it's all good to identify a need for a service and a program, but one should also consider the barriers to access to those programs, break down those barriers to access, to actively promote the service, this new service, so that it is actually taken up. Suggestions were to use resource mapping, seeing what you have already to prevent, you know, doubling up, perhaps with working together, mainly to identify those population needs and the service gaps. I mentioned before about being more proactive about raising awareness of the programs in that targeted community and minimize barriers to access. So those were the factors we found. As I said before, that we're not making any sort of claim about these are the in order of most importance or strength of evidence or anything like that, but certainly factors that were reported by those programs that did attempt to scale up a mental health program at scale. So certainly factors to think about.
Great, thank you. Well, thank you very much, Carol and Kelly and the whole EPPI team for all the in-depth work which you've been summarising. But there's a lot of detail in the full report which I strongly recommend you to look at. There is a positive, there's a very positive story to a lot of this. I mean, that how many of the different interventions do have, you know, positive effects, and that's not always the case in these kind of systematic reviews. And I hope that is taken on board by decision makers, not least in a week when we're probably going to hear about pretty stark public spending cuts hitting many services. So the resource point which you raised at the beginning, obviously I suspect was going to be in the forefront of some people's minds in the near future. So we're now going to hear from Siobhan O'Neill, who chaired the advisory group for this review, is a professor of mental health and also Northern Ireland's mental health champion. So someone who really understands both the supply and demand side of this, to go back to what Carol was saying. Siobhan, over to you.
Hi, good morning, everybody, and thanks for having me on here today to speak about this. So just to start off, I want to welcome the report and the review. It's really helpful to get reviews of this type because there's been so much research, mental health research relating to the pandemic and everything around the pandemic, and lots of people are interested in this, but it has led, I think, to a selective use of various different studies to construct particular arguments, right? And that's fine if you're a group that's interested, particularly in children or whatever section of the population. But actually, we do need these sorts of reviews so that we can get the bigger picture and so that we can understand even the variation in the percentages there and the confidence intervals and everything. So I'm just so glad that the report's there. So I'm going to just go through a couple of things that sprung to mind when I was listening and reading through the final documents there as well. So right, anxiety was something that we know anxiety increased. There's a big difference there. You know, the range is quite large, 21 to 52% of people. And for me, that's really important in terms of our understanding of mental health and the stress response and how we respond to a threatening event. And knowing the difference between anxiety and clinical levels of anxiety is all really, really relevant there. And this maps on very nicely to actions 1 and 2 of our mental health strategy here in Northern Ireland. We're currently rolling these out or planning them, and that's around increasing the population awareness of their stress response, of what mental health is and what it isn't, and what anxiety is, and all of those things. So I think that's particularly interesting there. In terms of depression, we know depression can be harder to treat in some ways. And much of the treatment at the minute is medication, and that wasn't included in the review. So I think that's interesting as well, that there's so many other interventions that work, those talking therapies. And we're limited there in terms of the therapies that have been studied as well. I'm conscious of that. So CBT is back there as one of the main effective treatments, but we need to be rolling that out. I mean, we still have mental health services in Northern Ireland where it's very difficult to get access to psychological therapies. So that's a huge thing for me. And even in terms of children and young people, depression's harder to prevent in that group. So we really need to be getting the treatments right. Whereas in that group, we can start to address anxiety. And again, that's really reassuring because there's a lot of work happening in our schools now to prevent mental health problems, to increase resilience. But a lot of schools feel that they don't know where they should be going or what they should be bringing in. So this is solid evidence there as well. So let's look at adults again. Workplace interventions, really important, very interesting from a policy perspective, because a lot of workplaces, in fact, provide this stuff for free. They do it because they look after the staff, the people, and it makes economic sense for them to invest in it. So I think we need to be harnessing, you know, when we're into an era where there's very, very limited funds for mental health, that we need to be making the most of those workplace interventions, raising awareness of them, and also improving the uptake in workplaces and thinking about all those people who are in workplaces where the interventions are really good, where there's programs, but it's getting people in there. You know, and I think that's important. And then stigma is part of that as well. Psychoeducation, as I said, this is something we're targeting now in our mental health strategy rollout. And it's interesting that it's in there as a universal treatment, universal prevention for depression that seems to work. So that's reassuring too. There's a lot on digital interventions, and we're working on something I'm interested in myself. And what struck me about the evidence here is the need for that strong theoretical base and fidelity, and you know, almost the manualization of this stuff and translating it into digital. So you start with that theoretical framework, and then you then build on the digital, and it's digitally enhanced. So it's not about developing apps out there. It's about, you know, most of you will know this, but I think there's not enough awareness of the need to be translating things into digital interventions and to use digital to enhance what we're already doing. So digitizing is part of the scale up as well. But again, we need that fidelity. So what else do I have? Yeah, there's many interventions that wouldn't have been examined in the review just because it's quite a narrow review, and you know, we need to acknowledge that as well. And there's certain things that seem to work in various different populations that really haven't been subject to the type of trials that mean they would be included in this. So this shouldn't be all that we do, but it's a really, really important guide for us going forward. In terms of the scale up, I think awareness of the impact of universal interventions is still not there out there in the community, and in terms and our political leaders as well. You know, there's often lots of calls for treatments, but this idea that you can prevent mental illness from developing, that the things we do in communities impact people's mental health, we need much more awareness of that. Again, there will be a need for additional resources, so we need always to be adding on that cost effectiveness analysis so that we can make those arguments when we're asking for money to do these things. So in Northern Ireland, just to give you a quick update, our mental health strategy has currently been rolled out. There's funding for the first couple of years for it, and we will need more funding as the 10-year period progresses. But right now we are rolling out those actions in the mental health strategy in terms of treatments, but also the early intervention and prevention actions too. So I think it's important to make that point as well. But so thank you so much for this. I'm going to be using it. I'm going to be tweeting about it and sending it out to people, making sure that it's used to inform what happens on the ground in a policy level too. Thank you.
Thank you so much, Siobhan, and thank you for all your help through the whole of this this process, and indeed some of the events we were doing beginning of last year, which kicked this off. We're now going to hear from Nancy Hay. Nancy runs the Wellbeing Centre, which does a fantastic job in bringing together, in some ways, a much wider body of knowledge and evidence about all the things which influence our well-being, part of making that part of the political and policy mainstream. And after Nancy's spoken, there will be time for Q&A or comments, so please do use the chat for that, and my colleague Muiris MacCarthaigh will take over at that point. But Nancy, the floor is yours.
Thank you, Geoff, and really thank you so much to the research team here. This is a brilliant contribution, and the reason it is brilliant is a couple of things that are fantastic about it. One is that I love systematic reviews for policy making and for practice. They are excellent, and the reason they are is because they are rigorous and they're practical, and they avoid bias, who's shouting loudest, and they are transparent in their process, and it makes sure everybody is included in that policy making, and it really accelerates all of the things that all of us can do. So there's a huge amount of will to act, intention to act positively, and needing to know rapidly in one place rather than being pulled into different things depending on what we notice is super important. So just the approach is fantastic. Mental health is a really important overlooked area of driver of what it means to live well in just generally, and we've had 30 years, 40 years worth of research to catch up on. So what is super exciting here is that there is a good and growing body of evidence that we can use, and that it is a high quality, as well as really identifying areas of gaps that we know where to accelerate things appropriately. So we're not just rushing to an end result, we can build it up systematically and really learn collectively. So that's exciting. The other really interesting thing about this is that it's developing this field of population mental health or public mental health. And we've really seen how public health, as it relates to our physical health, has been at the forefront of tackling a global pandemic. And actually they do this day in, day out about how we deal with threats to illness, of health protection, but also of actively building the things that keep us well. So this field of public mental health and population mental health is really growing as a field of both study and practice. And we can see that in the quality of evidence that we have here. And actually, we just touched on that a little bit about how we're looking at, there's a treatment gap. So where we have effective treatments, getting that into practice, scaling that includes things like workforce development, how we make things cost effective, as well as just effective, and increasing access and connecting the right people to the process. I think one of the things I would talk about in that area is in terms of our intention to increase the access and take up of programs, we need to be really careful in studying, are we also affecting mental health as well? So there's the real challenges around using mental health diagnoses, mental health treatment as signifiers of things getting better or worse, which is why this data is quite helpful, because it puts that into a broader sense. So we've been deliberately trying to increase take up of awareness of mental health and take-up of mental health treatment, including self-referral, over the last 10-12 years. And in doing that, sometimes the good intention can actually make things worse, or we at least need to study whether or not it does. And so thinking about that aspect of intervention rollout as well, which I think is really interesting that you had that implementation. I'll come on to that in a second. The other aspect, of course, is treatment. Then you've got prevention, and we're making huge, and then promotion, and it's sort of building the things that keep us well, help us be resilient. And that prevention one is really exciting area of growth. So suicide prevention in particular has accelerated hugely during the pandemic. It was already making good strides. It's a really difficult area. But for example, that's an area where data has really come into its own, and we can start to see some effective practices in that area. And then we've got the promotion of good mental health, of good mental well-being, and building of mental capital. And again, that is growing hugely as well. So understanding where you're intervening and why you're doing those different things is really important to understand. And this is starting to help us really unpick that. But the analysis of need at the beginning, which I think is really exciting, of this prevalence of anxiety, a prevalence of depression, increased likelihood of PTSD and other types of mental illness, is really interesting. And so, and data is really key to this, in that consistency of metrics, the consistency of concepts that we're using. And so you'll have heard sort of, for example, in the discussion about the budget today, or the autumn statement today, that the discussions around how the financial crisis and the cost of living is creating anxiety. And we've got those anxiety data in the national metrics in the UK. And actually it's collected in many, many countries globally, increasing levels of detail. And it would be a fantastic area addition to the SDGs, for example, is having proper mental health and well-being metrics, not just physical health metrics, though the goal is health and well-being. The metrics could usefully be along there, and that would help us compare and learn really rapidly in a range of different contexts as well. I liked that we had across the life course approach here, children, young people, primary, secondary, working age, community, different contexts, different settings for mental health interventions in the same way as you do for public health. I mean, I also know, because we work on it, that there is actually a growing evidence base around higher education and colleges as well. So these interventions that we know work in different contexts, can we transfer them across? Do they work in these new settings? And that's an exciting one. Interventions that work in a group setting in communities, can they transfer across to the workplace? Can they transfer across to students and things like that? And that is what this sort of body of evidence helps us do safely in a really exciting way. The thing that we also see from that national metrics is this, it just sort of reveals stuff we already were feeling. So just because we didn't have it before, we still, so 40 years ago, I would argue probably mental health was way worse. We just didn't measure it. We are starting to see that trend again, unhelpfully. So I think it's important that we now have a better position to measure and respond more quickly on both sickness, distress and wellness. So the sorts of things that we can start to see is this feeling of exhaustion that so many people are experiencing in working age, and it is coming through in these metrics. That existential crisis we had, that threat of death in later life, starting to also come out in the sort of hunting of pleasurable activities, things that really lift our happiness, not just show our depression is coming through. And you can see that sort of different population segments. So parents that were working at home during the pandemic, we could see had experienced the highest level of psychological distress. And so that allows us to really tailor these interventions, and that might help us be more effective and more cost effective if we're working out who we're providing to, and when a universal thing is appropriate and when a targeted approach is important. We'll just publish some of the latest analysis of the anxiety data in the UK here from the quarterly statistics. Have just gone out today, actually, our analysis of that. So I also wanted to talk about how we grow this evidence and why it matters that this type of work is, this review will help draw us an evidence base that we can really accelerate from. So there are population level interventions that have a positive impact. We know they work. How can we scale them? There's lots of will and intention to act. how can we do that scaling intelligently, and particularly where we're doing stuff, can we learn from it as well? So one of my bits of learning from the pandemic was we were doing lots of stuff, we were not necessarily investing in that learning, and that comes out really clearly from that report. Otherwise we'll be in the same situation in 5 years' time if we don't learn from what we're doing. Thank you.
Excellent. Hello, everybody. As Geoff says, Muiris MacCarthaigh is my name. I'm in Queens. I'm the Northern Ireland lead for the IPPO team. And as throughout this project, Geoff and I have been a bit of a tag team. So he said he'd do the first half and I do the second. The floor is open if anybody would like to, and I see their questions in the chat, but if anybody would like to raise a yellow hand or unmute and just voice something. And would it be unfair, Kelly or Carol, maybe to, you might have some responses? I mean, as has been said, the scale of this is so big, we can't do everything. We couldn't do everything. And a lot of it has been trying to do the best we can in the time we had and the resources we had. But you might have some responses, Kelly or Carol, initially to questions that you might have seen in the chat. Kelly or Carol, do you want to unmute and say something first? And then I'll and if people, Nancy yourself as well, want to put links in the chat to anything, any recent reports or work that you've been involved in, we'd be very, very pleased to see about that as well. So Kelly, oh great, there you are. Kelly, I don't know if you...
I'm here. Yeah, I think there was a question earlier on about thinking about schools. One issue with workplace interventions is creating a reflective space that actually feels safe for staff. Do you have any evidence on how this might work? No, not directly, but there was some evidence on kind of mental health first aiders, mental health champions, and that so people have somebody other than their line manager to talk to, as well as kind of existing EAP, so employment assistance programs. But some of the issues is about making sure people are aware of them and can access them. So, but yeah, I think the mental health first aiders, would be existing staff, which is an example of kind of training non-specialists to become kind of specialists in the workplace, which I think leads to Eleanor's question. I'm not sure if Carol wants to say anything about examples on.
Hello. There's more in the report about specific examples from each of the papers that contributed to that theme, but I think it was closely related to kind of a stepped care approach, so that the first point of contact may be non-specialist, but the specialist support is there. It's not it's taking a more perhaps targeted approach. So when people self-refer to perhaps a non-specialist who's already in their life, it may be community health workers or caregivers too, whereas included perhaps in this. So more specific examples in the report, but I think for me that was the sort of the key point. It wasn't just a complete shifting away from specialists and doing it on the cheap, if you like, but it was very sort of considered targeting upskilling rather than task shifting. I prefer to people. It was also most often manualized, most often for common mental health disorders, but people also skilled in good referrals, and the support was also there.
Yeah, the example in the UK would be the kind of psychological wellbeing practitioners, and there's a rolling program of training actually at UCL and other universities that go directly into increasing access for psychological therapies, and they would be the first point of contact, and they would be able to, they deliver like guided self-help CBT model. So that's why it's linked to so it's much quicker. It's not a 3-year CBT training, it's like a 1 year. But yeah, it's still a form of specialist training. I think other examples, Carol, would you say kind of community health workers?
Yeah, definitely.
So people who are already in existing social care roles, who are coming into contact with people with mental health difficulties, having additional skills training.
Thank you so much. Oh, sorry, Carol.
No.
Putting across everybody at the moment. There was another question in there, sorry, from Charlotte about the workplace sort of reflective space, I beg your pardon, for staff.
Yeah, I did mention that the mental health first aiders is another example of the kind of upskilling, but mostly having somebody other than who you work with to be able to talk to. But it's very much a referral service, so as well. So it would be somebody that you'd speak to, you would be able to make an assessment, and then if they needed more specialist support, then they would know who to refer people to. Again, it's a similar, like a step care model.
Yes, indeed. Thanks very much, Kelly and Carol, on that. And we can see, as often happens to these, it's in the final quarter, the questions start flying in thick and fast. So we'll try and field as many as we can. But obviously, today does not represent the end of this work at all. It is very useful for us to hear about what people's concerns are, and also for people to share in the chat as well any good practices or links, as you're already doing. There's a question from Mark about integration between individual and community level interventions in mental health promotion. Mark, go ahead, unmute there quickly and explain. Sorry.
Thank you so much.
Hi.
It's been a great event to be part of. I'm sorry, I missed the beginning of this, so apologies if this has already been partly covered. I'm Mark Williamson from Action for Happiness, and the question, as I hinted at in the chat, is about I think something that's really hard to evaluate, but I wondered if it's something you've seen any kind of early indications of evidence on. But the integration between what starts as an individual-led intervention, but then links in directly to wider community support, particularly peer-to-peer support. So, for example, we have hundreds of thousands of members of our sort of community of Action for Happiness, people sort of seeking and providing support to each other, and they might start with a one-to-one digital course. We have an online program that is shown to boost well-being, but the key thing, and actually what's really interesting, is a lot of mental health funders, philanthropic funders, are now saying to us that's what's most appealing to them in terms of what to back in the mental health, what to invest in the mental health space, is things that don't just have that sort of digital initial interaction, but can actually bring somebody into a lasting community. So we then have, for example, 200,000 people on our app interacting with each other on a peer-to-peer basis and getting support through that. And people might go to a local group that's run by volunteers where they can meet, and it's a sort of peer-to-peer wellbeing support model. So it's really hard to evaluate these things because of the complexity of that. But we feel that, and in fact, people tell us that one of the advantages of that approach is you get much more longevity. Somebody who might take a digital intervention on CBT or whatever initially might then stop. And actually what this integrated approach allows is you stay involved, you have that ongoing peer-to-peer support that takes what would otherwise have been a 10-session experience into a multi-year sort of lasting intervention. So sorry, long-winded scene.
No, that's very,
have you seen any evidence around that integration between one-to-one and community peer support?
Not directly, but I think that is the nature of the systematic reviews and the way that they define the intervention and keeping it quite singular. But I was surprised, and it could be our inclusion criteria or meta-analysis, that we didn't find those kind of informal peer support evidence on that. But that doesn't mean it's not there. So I think that's one for the gaps in the evidence base.
But that's really interesting observation, actually, Mark, for everybody here in the call to know about that. I mean, it sounds, actually, if you could put a link maybe or anything like that, Mark, in the chat as well.
Happy to, yes, thanks very much.
No, thanks very much. There's a question there from Tina about people's thoughts on organizations and systems becoming trauma-informed, which is accessible training for everyone. Is that a sort of a certified thing, Tina, if you're there?
Hi, there's a lot of talk about it. Again, I'm a member of something called the Wave Trust.
Okay.
They have a campaign to reduce adverse childhood experiences by 70% by 2020, and they do a lot of trauma-informed training. But it is something that's being discussed across organisations, but there doesn't seem to be a standard for it. But basically, if every member of an organisation has a basic awareness of what trauma is and how to talk to people, it can really, really bring down level of stress within an organisation. So
great. Actually, thanks very much, Tina. Sorry to be so brief with you. I can see actually Nancy has posted a very nice link there to work that our organisations involved in as well. So thanks for that. I might move on to Elaine's question there about details of exactly what level of supervision and support really work for
Muiris, we covered that. We went
beg your
straight
pardon.
from. Yes, all right.
Yes. Do you know what I'm getting? Oh, look, I've scrolled so far back up the page.
So the psychological wellbeing practitioners looking at the social care literature, I think, around sort of examples of community health workers. So it's people already kind of in existing roles and then having that additional training. But often it might be in a referral work situation, so that they part of the step care, so that they would be referred to someone who's non-specialist. That might be enough. Yeah. And that's fine. And then, but if not, that there would be a referral pathway there.
Thanks for that, Kelly. And thank you, everybody. It's super, everybody putting up links that I'm sure others on the call here this morning will find helpful about work that they know of or that they're directly involved with as well. Nancy, Siobhan, I don't know if you'd, if anybody else wants to unmute and ask a question at this stage, it's a good time to do it. If you haven't had a chance to type it in, or if there's anything, no obligation, Nancy or Siobhan at all, if you wanted to add to the discussion that's been going on, please feel free to do so as well.
I just wanted to come in on the ACEs and trauma-informed stuff as well. So one of the challenges in intervening on that is to really understand what these things are and what the theory of change is, what is it, the concept you're trying to do, and how to understand the evaluation of it. And so I've just put in the chat one on adverse childhood experiences, where there's been a huge amount of work trying to unpick what it is we mean by that, what it is, how we use it effectively in an evidence-informed way by the Early Intervention Foundation, including with Public Health Wales, and also with on trauma-informed approaches, particularly in children's social care, and really understanding how we can build that evidence base around it, because it needs a little bit of a journey going on, because there's lots of interest in it, huge amounts of goodwill, lots of enthusiasm, but we really need to understand what it is, how it works, in order to do those scaling things identified in this report. And that's important and really boring if you're really wanting to get on with it. But it really matters how we systematically build this up, because we've got 40 years worth of research to catch up on.
Yeah. Thanks very much, Nancy. Sarah's just putting, people agreeing with you, which is always nice, Nancy. Sorry, Siobhan, I thought you were going to say something there earlier. You looked like you were about to, but maybe not.
I put it into the chat, but it's just agreeing with what Nancy said, and also saying that it starts with that attitude shift, which is very difficult to measure. But yeah, we do need to try and find a way of pinning this down and the key features of it, so that we can measure the effects and scale it out. And that's something I'm facing as well as I talk about trauma-informed practice and ACEs.
Brilliant. Thank you very much. Okay, so listen, a last call if anybody would like to, thanks Nancy for putting that up. Anybody would like to ask a question of Kelly or Carol or Nancy or Siobhan. Robin, yes, you might be the last intervention we get here. Please go ahead.
Hello. Yeah, this has been a fascinating session. Clearly, money spent in prevention is money well spent, but it's very difficult to make the case for that with NHS bodies and ICBs and so on. Do you have any advice on this? Because clearly, I mean, dementia prevention, for example, there are mid and late life factors, risk factors, and, really targeted communications at certain times of life might reap benefits, but it's very difficult to get anybody to invest in that.
Do you work in the sector yourself, Robin? Sorry, I don't know.
I do, yeah, and I'm a family carer for somebody with early onset.
Okay. Got you. Okay. I imagine that's the $64 million or $1,000 question, isn't it? Siobhan, you unmuted there.
Yeah, I'm just putting in the chat there the report from Mental Health Foundation, where they have established the economic cost of mental illness. It doesn't include dementia, though. That's the thing. But they've also identified the best value where there's an evidence base for cost effectiveness. And early intervention prevention is very strong, and there's only about 11, I think, identified interventions that really that really got that evidence-based that work. Things like anti-bullying programs in schools, parenting programs, workplace programs, brief psychological therapies. So it's a really, really important document. I use it lots, but that does make the case really well.
Oh, could we get a link to that, please? In the
yeah, I put it into the chat. I just put.
We're already done, Robin. We're that efficient in IPPO. It's already in the chat. So there you go.
Thank you so much.
Thank you, Robin. Okay, I think one of the sort of characteristics of IPPO is these short, relatively high-level sort of sharing of information, and we do try to stick to time very much because we realize, I don't think we realize how under pressure people working in the sector are, and we have an ambition to finish at 11 o'clock, which is about in 1 minute's time. So I think it just falls for me to thank, first of all, everybody for coming along today. Secondly, to thank all of our speakers, and in particular, I have to say to Kelly and to Carl and colleagues in the EPPI Centre, it's an enormous amount of work. When we got the funding for IPPO, we just had this generic, I suppose, well, we had some ideas about mental health, but it very quickly opened up this huge amount of research. So to gather it and make sense of it over time has been extraordinary, and it is something we're trying to work out the future of IPPO. Our funding was for 2 years. We're trying to work that out at the moment, but clearly, this is the shadow pandemic. I don't think I need to convince anybody on the call here, but it's not something that's, we now park and move on to something else. Far from it. I think this is a brilliant community of people here today working on these issues. So hopefully we can grow it and share information, and, IPPO hopefully will be part of this, facilitator of knowledge sharing and helping with better outcomes ultimately for people. So thank you all for your time. Thank you to my colleague Geoff, and to everybody else in the IPPO team, and of course the advisory committee as well, which Siobhan chaired. You're all acknowledged in the acknowledgements to the report. So yes, thank you all, and enjoy the rest of the day, and hopefully you find the publications useful, and that we see you back at future IPPO events, all going well. Thanks very much.